Thank you all very much for a very productive day yesterday. And we were going to start off with a little bit of a recap. I think Jeff is going to start that, and then we'll shift into session 5. So take it, Jeff. Jeff and
All
Steve.
right, thank you. Good morning, everybody. Welcome back. Jacob, could you put up the slide we prepared for this opening? But I'll kick it off and say Terry has asked both Stephen and myself to just provide a brief recap of what we talked about yesterday. So I'm sure our ideas are somewhat more focused than maybe you all, your ideas of what we talked about yesterday. But we came up with about 6 major themes. There we go. And the first one is on the topic of enhancing early diagnosis with sequencing and biomarkers. And we heard a significant call to prioritize the use of rapid genome sequencing and biomarkers like TREC for early detection of severe combined immunodeficiency and other inborn errors of immunity. In that discussion was a call also to develop algorithms that would help trigger sequencing based on clinical phenotypes, also to use family history to improve diagnostic rates and outcomes. We thought the discussion warranted a call to develop robust and harmonized phenotypes for infection. And in the end of yesterday, we heard about the need for genetic counseling to be integrated with genome sequencing, particularly for secondary findings. Whoops. Can you, for some reason, the slide went off when I wanted to advance it. Can you put the slide back up? Thank you. There we go. The second point was to foster better integration between the communities in immunology and infectious disease, hoping to strengthen collaborations between immunologists and infectious disease experts to enhance our understanding of treatment strategies for both common and rare infections, to promote multidisciplinary teams to better identify cases that would benefit from genome sequencing. And we even had this discussion at dinner last night, to think about an entity like a tumor board that would bring disciplines together to improve infectious disease diagnostic treatment recommendations for specific cases and patients in various institutions. The third area was to expand data resources and tools for clinical applications with the notion of creating forward-looking genomic databases and comprehensive annotations of genes and variants coupled with clinical and immune phenotypes, but also to include social determinants of health and various exposures, including environmental exposures with those data. And alongside the database idea was the idea to develop tools like improved family history, health history modules for identifying immune deficiencies and genetic susceptibilities to infectious disease. The fourth idea that we heard was really to take on driving policy and reimbursement strategies and to advocate for really demonstrating conclusively in multiple settings the cost effectiveness of genome sequencing for accelerating diagnoses and to maybe prove that, that this reduces hospitalization, patient outcomes, and reduce costs, to engage payers in collaborative studies to enable evidence-based coverage decisions. The fifth idea was to promote international collaboration and to explore opportunities for population scale genomic data in the infectious disease community, and particularly to collect and address underrepresented populations and global health challenges. And we certainly heard in the talk on the Pacific Islander research the benefits of doing so. The last area that was covered yesterday was the host response technologies and the opportunity to advance these. I think we heard that sepsis is a challenging area that we probably shouldn't wander into too much, based on what we heard yesterday, but that point-of-care testing for bacterial and viral infections really does hold promise. Adoption will depend on demonstrating clinical utility, probably also cost-effectiveness, and at least in my mind, even thinking about how using a B versus V test could reduce antimicrobial resistance. And across the board, really important is to ensure that all the research studies that we contemplate coming out of this meeting bring a diversity of participants and patients and their data throughout all these themes. So that's a quick synopsis of some of the major ideas that emerged from yesterday. Steve, ask you to see if you want to add anything to this list. Or
We were particularly enthusiastic about the proposal for NHGRI to fund this.
How many glasses of wine did you have when you specifically had that hallucination?
So no, I think, you know, all of these kinds of things have application to both institutes, and we'd hope, I mean, we couldn't do this alone without the subject matter expertise, so.
And does anybody around the table want to add something that, glaring that we missed in the summary just before we kick off today?
Well, I don't think it's glaring, and I think it falls under tools, but informatics approaches to identify patients from the EHR who might benefit from being evaluated for an immune deficiency.
And I just thought in your first point, you really do need to make a bright distinction between screening and diagnosis.
And I would note there will be more time to discuss these at the end of the meeting. We just wanted to get everybody back into the, you know, gestalt of what we did yesterday. So thanks, Jeff and Steve. All right, so I think next, if you'd hand it to Carol, and she will hand it to Peter, and they will take it from here.
Great. So this is the session on pharmacogenetics and infectious disease management. And our first speaker in this session is Peter Steyger, who's going to talk about aminoglycosides, clinical settings, and pharmacogenetic variants mediate drug-induced hearing loss. Peter.
Thank you, Carol, and I'd like to thank the organizers for inviting me to present this morning, and I'd like to start this session by introducing the need to better understand how hearing loss and the other toxicities that will be described by my fellow presenters today are caused by hospital-prescribed medications, and how these toxicities can be mediated by genetic variants, many of which are as yet unknown, and that these toxicities can also be mediated by inflammatory settings. So, hearing loss affects more than 1.5 billion people and is the third most common cause of years lived with disability. And over 50% of hearing loss worldwide is acquired, for example, by excessive noise exposure and by cisplatin and aminoglycoside antibiotics. In other words, this is acquired hearing loss and is potentially preventable. And hospital-prescribed medications are a major cause of hearing loss. And known genetic variants and known genetic variants can exacerbate permanent hearing loss. Nonetheless, aminoglycosides are highly potent, broad-spectrum bactericidal agents for treating severe infections worldwide. Aminoglycosides are cheap, widely available, and can be readily transported at ambient temperatures, which make them especially effective for treating tuberculosis in regions with little ability to refrigerate pharmacotherapeutics. In the US, aminoglycosides like gentamicin are used to treat suspected or confirmed neonatal sepsis in the NICU, while other aminoglycosides are used to treat respiratory exacerbations in those with cystic fibrosis or immunocompromised patients with non-tuberculous mycobacterial infections. Thus, aminoglycosides are still used today despite the known risk of nephrotoxicity and ototoxicity because they are life-saving drugs. And I'm going to be primarily talking about ototoxicity today. Ototoxicity is best defined as a pharmacological damage to the inner ear due to exposure to pharmaceuticals, among other agents, that lead to lifelong hearing loss and also vestibular deficits. I'm going to be primarily talking about hearing loss today, but the vestibular deficits are equally devastating, but is under-researched compared to that involving auditory system. The bactericidal effect of aminoglycosides is through their ability to bind to 16S ribosomal RNA of bacterial ribosomes, inhibiting protein synthesis. Mammalian mitochondrial 12S RNA, which is encoded by the gene mtRNR1, is homologous to bacterial 16S RNA, yet it has a less binding affinity for aminoglycosides. However, particular variants in the mammalian mtRNR1 gene increases this binding affinity to aminoglycosides, leading to a far greater risk of permanent aminoglycoside-induced hearing loss, as first reported in 1997 by Pandya et al. And the incidence of this A to G1555 variant in the mitochondrial RNR1 is between 1 to 500 to 1 to 1,000 in Europe and the United States, respectively. And there are other mitochondrial variants that can bind to aminoglycosides, though they are less frequent and present with conflicting reports of any enhanced risk of aminoglycoside-induced hearing loss. The incidence of aminoglycoside-induced hearing loss with the A to G1555 variant is extremely high and can occur with as little as one dose of aminoglycosides. However, in the UK, an award-winning bedside assay for the A to G1555 variant has been developed on the GeneDrive platform, and positive identification of variant will alter treatment to less ototoxic, more expensive antibiotics. This test is non-invasive, simple to use, and can deliver results within 1 hour, the golden hour, very much like the Inflammatix platform that we heard about yesterday for sepsis. This rapid diagnosis can preserve lifelong hearing for those with mtRNR1 variant, giving them the ability to better acquire listening and spoken language skills like their age-matched peers. This is particularly true for children. And this assay is now undergoing a multi-center clinical trial in the United Kingdom. Moving on to patients that have cystic fibrosis, they often experience an exacerbated respiratory infection that are also treated with aminoglycosides that are life-saving in this instance. Aminoglycoside-induced hearing loss is typically dose-dependent, and onset of hearing loss first occurs at the higher frequencies, and continued dosing leads to hearing loss of progressively lower frequencies, and these tend to be within the frequency range of human speech and conversation, like in this room today. Yet, aminoglycoside-induced hearing loss occurs in as many as 54% of cystic fibrosis patients. And this chart here shows clear variability in the degree of aminoglycoside-induced hearing loss. A fraction of patients with cystic fibrosis appear to have exacerbated hearing loss. In the lower corner here, down here, they seem to have exacerbated hearing loss down here, and a substantial fraction of patients, despite high cumulative dosing, have very little or no hearing loss, and we tend to call these golden ears. Thus, there is phenotypic variability in outcomes following aminoglycoside treatment, which is suggestive of an underlying genomic variability with some as yet to be identified variants resisted to aminoglycoside hearing loss, while other variants may predispose individuals to toxicity. This phenomenon may also be true for another antibiotic, vancomycin, but much less research has been done in this area, yet it is prescribed even more frequently than aminoglycosides themselves in the United States. The Cystic Fibrosis Foundation is funding a multi-site study in around which is enrolled around 500 subjects to determine if specific genomic variants predispose individuals to aminoglycoside-induced hearing loss, or alternatively, to prevent aminoglycoside-induced hearing loss in those with cystic fibrosis and treated with aminoglycosides. A GWAS analysis is now underway to assess if any gene variants are associated with this increased susceptibility or resistance to aminoglycoside-induced hearing loss. So I'm going to move on to preclinical models of ototoxicity. And most preclinical studies of aminoglycoside-induced hearing loss to date have been conducted in healthy animal models, particularly guinea pigs, rats, and mice. Yet clinically, aminoglycosides are only given to those with severe bacterial infections. Severe infections are known to modulate the permeability of the blood-brain barrier, and the inner ear itself is protected by a similar barrier called the blood labyrinth barrier. And similar infection, it keeps out the toxins, macromolecules, and blood cells from entering the inner ear itself. We used a model of bacteriogenic systemic inflammation induced by LPS given intravenously to better model the clinical conditions, and we found that this type of inflammation increased the cochlear uptake of aminoglycosides. And so what I'm going to show you here is a chart where along the x-axis down here, which we move away from the origin, we see increasing frequency from 4 to 32 kilohertz, and on the y-axis over here, we see a threshold shift from baseline to the audiogram after treatment, and this shift and further up the y-axis means an increasing degree of hearing loss or change in hearing in those animals. And what you can see here, that animals treated with just LPS alone, this red line, is hardly different from those treated with saline for over 3 weeks. When we treated these mice with kanamycin alone, we see a little change in their audiograms of threshold shift, which is not significantly different at the lower frequencies, and we see a higher frequency at the 32 kilohertz, which was deliberate and significantly different, and this shows that we are giving a dose of the ototoxin, aminoglycoside, to a small degree at the very high frequency. But when these mice are treated with both LPS and kanamycin, the degree of hearing loss at 32 kilohertz is significantly greater from those treated with just kanamycin alone, and also extend for lower frequencies at 24 and at 32 kilohertz. This suggests that the very individuals who most need aminoglycosides are at even greater risk from the host immune responses to bacterial infections, potentiating the degree of hearing loss from the aminoglycoside treatment. We validated this hypothesis by using null mutants for components of the TLR4 pathway, and here in this particular example, there we go. Sorry. So I'll start again here. We tested this hypothesis using null mutants for components of the TLR4 pathway. And here, this is a null mutant for TLR4, and we found negligible changes in the null mice in those treated with aminoglycosides and LPS from those that were treated with just saline alone compared to the wild-type mice. And null variants with similar outcomes after treatment have similar outcomes after aminoglycoside treatment with healthy wild types. And these include the null mutants for MyD88 or TRPV1. So So I would like to close by summarizing and raising the need for further research in this area by summarizing here. And so what we have here is that a point-of-care mitochondrial mtRNA1 variant assay has been developed and is now in clinical trials. Can similar bedside assays for variants in aminoglycoside-induced hearing loss give similar results in the golden hour? And gram-negative inflammatory responses can exacerbate aminoglycoside-induced hearing loss, but we have questions here. Can gram-positive inflammatory responses increase the risk of aminoglycoside-induced hearing loss during synergistic dosing with ampicillin, for example? And does empiric or beta-lactams, does empiric aminoglycoside dosing for unspecified infections, which typically occur in the NICU, when these unspecified infections may be viral, can they also increase the risk of aminoglycoside-induced hearing loss when they are used? So mitochondrial genomic variations typically don't have a phenotype, an auditory phenotype, until there is ototoxin dosing. And those variants could increase the risk for hearing loss during treatment, or they could indeed decrease the risk for hearing loss during treatment for infection. But we need to do a lot more work to figure out how much of an impact genomic variants can have on the impact of aminoglycoside treatment on hearing. And null mutants of genomic genes involved in the inflammation can attenuate aminoglycoside-induced hearing loss, but how many more genes are involved? Is it just in the inflammatory genes, or are other pathways involved, such as antioxidant defenses, transport pathways across the blood-brain barrier? Do they impact the trafficking of gentamicin and other aminoglycosides into the inner ear? Candidate variants exist in antioxidant genes associated with cisplatin-induced hearing loss, yet there's conflicting data, probably due to heterogeneous cohorts of individuals recruited to those studies. And so susceptibility and resistance to aminoglycoside-induced hearing loss may be polygenic, as has been described for age-related hearing loss, which further complicates the identification of settings in which pharmacogenetics may be used to prevent aminoglycoside-induced hearing loss. And so, thank you for your time.
Thank you, Peter. Our next speaker, Aniwaa Owusu Obeng, is going to talk to us about from theory to practice, navigating strategies and barriers in the clinical implementation of Voriconazole pharmacogenetics. Aniwaa.
Thank you, Carol, and good morning, everyone. Thanks, Terry, for the invitation, and thank you all for the very engaging conversation yesterday. Today, I would like to talk to you about Voriconazole pharmacogenomics, and I'll give a quick, brief overview of the pharmacogenetics and the CPIC guidelines, or the Clinical Pharmacogenetics Implementation Consortium guidelines. And then I'll highlight some of the barriers and how we are navigating those barriers in the Mount Sinai Health System in New York City. So starting off, I don't think I have to go much into voriconazole for this group, but it is a triazole antifungal agent that inhibits the ergosterol synthesis, and it's approved for the treatment of invasive aspergillosis and candidemia. But most importantly, what I want to talk about today is that the IDSA recommends voriconazole for primary therapy of invasive aspergillosis and also as alternative therapy for candidemia, and it's also used for prophylaxis. However, the current CPIC guidelines are only for the treatment use of voriconazole in invasive fungal infections. And if you know anything about the pharmacogenetics of this, you know that CYP2C19 is the culprit gene here. So it's mainly metabolized by CYP2C19. However, voriconazole is also an inhibitor of CYP3A4, CYP2C19, and CYP2C9. Voriconazole exhibits wide interpatient variability in plasma concentrations. We know that this is due to some genetic aspects, but also due to age, also hepatic function, concomitant medications, and even inflammation, which Peter just mentioned in regards to the aminoglycosides. We are starting to see more information on this in literature about how inflammation phenoconverts people from one genotype or phenotype to the other. But today, I'll be focusing on the CYP2C19 alleles here. So CYP2C19, there are 5 main categories, maybe 7 if you talk of the likely phenotypes, but 5 main ones. So there are the ultra-rapids, which are individuals that carry 2 copies of the increased function allele. You have the rapid metabolizers, those that have 1 normal and 1 increased function. And the normal metabolizers, intermediate, and poor. Poor metabolizers carry 2 copies of the no function alleles for 2C19. One thing that I wanted to highlight are the notable frequencies here. We've been talking a lot about global participation and having representation. So let's just take a look, because these are the phenotypes of interest with voriconazole: the ultra-rapid, the rapid metabolizer, and the poor metabolizer, if I can get the cursor to go down this, but it won't. So ultra-rapid metabolizers, you're looking at roughly about 5% of Europeans, 4% of African Americans, and about 3% of Hispanic Latinos and Central or South Asians. Now, on the flip side, if you look at the poor metabolizer rates, this is about 57% of Oceanian population. We heard a lot about the Samoans yesterday. So you're looking at that. That's more than 1 in 2. So if you flip a coin, that person may actually be a poor metabolizer in that population group. You're also looking at 13% of East Asians and 8% of Central and South Asians fall in this category. Mind you, this is not only relevant for voriconazole, it's also relevant for a lot more medications such as Plavix and others that go through the CYP2C19 pathway. So for the CPIC recommendations for voriconazole, it is recommended that for ultra-rapid metabolizers, because they have a low probability of attaining therapeutic levels for voriconazole, and the chances here is that the trough levels are set between 1 to 4 micrograms per ml, and that's the suggested trough for treatment. Right, so for rapid and ultra-rapid metabolizer group, because they clear the drug too quickly, they do not attain, or they have a very low chance of attaining these therapeutic levels. Now, on the other side, where you look at the poor metabolizer group, these individuals have a higher dose-adjusted trough concentrations and may increase their probability of adverse events, such as the ones I listed here: hepatotoxicity, neurotoxicity, some visual disturbances, skin rash and photosensitivity, and others. So that's what the recommendation recommends against. So for these groups here, it is recommended to choose an alternative agent. For the ultra-rapid and the rapid metabolizers, the agents are isovuconazole, liposomal amphotericin B, or posaconazole. The poor metabolizers, if voriconazole is still warranted, you can consider it, but at lower doses than the standard doses. So these are the recommendations that we have to work with. Now that brings me to our implementation program for pharmacogenomics at Mount Sinai. We have a threefold aim, and the first is education and dissemination. The second is clinical implementation, and lastly, translational research. I was tasked to talk mostly about the implementation, so I'll talk about what we've been doing. So we realized that there are a few challenges, there are a lot more, but we just chose to highlight these ones. The first one was the lack of awareness and education that we realized among our clinician group. So in 2014, Casey was here earlier yesterday, so she worked with our team, and there was a paper published in 2014 of how we had surveyed the providers in our primary care clinics, and we asked the question, how often do you perform genome-guided genome-guided prescribing, and about 91% of the group that were surveyed had never used any genome-guided prescribing in 2014. So we knew that, okay, this is not something that they're doing routinely, or they may not be well aware of it, so how can we get them to use this more? So we started with building these one-pagers. So we have a one gene summary in the institution for every pharmacogenetic gene. This is the example for 2C19, where we talk about the phenotype groups, we talk about estimated frequencies and implicated medications, if there are any strong inhibitors, inducers, and so forth, and any other clinical considerations for each of the gene. In addition to gene summaries, we have drug gene summaries. So this one here is an example for efavirenz here, and then also there is one for voriconazole. We try to keep these to one-pagers, which is basically a summary of the CPIC guidelines for that particular drug gene summary. In addition to those, for our prescribers, we do a lot of grand rounds and faculty meeting updates, and we've also introduced CME programs and the reference cards. We've built different reference cards, giving them guides on how to counsel their patients when the results come back, in addition to some of the summaries that I showed you earlier. For our pharmacists, we've developed a pharmacogenetic certificate program that is in-house, and we recently graduated 9 pharmacists from this program for the 2024 version. 2025 version is starting in January. Hopefully, the aim here is really for our pharmacy department to be fully certified by 2030 is the goal, so pray with me. And we are trying to get everyone to be certified there. We also offer API rotations for the PGY1 and PGY2 pharmacy residents, and we have summer volunteer opportunities for student pharmacists. We also take medical students and genetic counseling students for their longitudinal research programs. I lecture in their courses within the Icahn School of Medicine as well, trying to incorporate more pharmacogenomics into their training. For patients, we have brochures and videos. So I'll show you the first one. This is our pre-testing brochure where we talk about what genes are, what pharmacogenetics is, and other things like that. It's a trifold, so the flip side looks like this, where it says your guide to pharmacogenetics. It has our contact information and other information there. We also have these pre-test video. The first one that has the high heels is just talking about everyone does not fit into the same shoe size, so why should you be, placed into one category for dosing? And it was supposed to play a little bit, but I'm not going to go into all of that. Then we also have drug-specific videos. This example is for Dapsone, where it talks briefly about pharmacogenomics. What we are creating for these drug-specific videos are 2 to 3 minutes long, briefly touch on pharmacogenomics, have a patient example for that drug gene, patient story example. And in this case, these are all developed, by the way, by the students that we take on rotation and for our summer programs. So the next challenge I wanted to touch on is EHR integration. How are we going to handle this? So the other question we asked in that same paper was, how often do you use decision support guides? Now, for this answer, we saw that over 90% sometimes use decision support or often used it. So we knew that, well, they're not doing genomics, but they use decision support. So how can we tie the two together? This was in 2014. So then we started building a program called ClipMerge. But since then, we've moved on to more commercial platforms. So this is the CPIC recommendation or the decision tree for CDS for voriconazole, where it tells you that if you see a voriconazole order initiated, you first check to see if the patient's 2C19 result is on file. If no, then you give them a CDS asking for them to get tested. But if they do have 2C19 on file, do they have a priority result? This is whether they are ultra-rapid metabolizer, or poor metabolizer. If so, you fire a CDS post-alert. If not, then there's no alert that goes out. So this is a sample alert that our clinicians would see. It would tell them that according to genetic testing, this patient is a CYP2C19 ultra-rapid metabolizer, and this status is associated with significantly decreased plasma concentrations of voriconazole and may increase their risk of therapeutic failure. So they should consider an alternative drug from the SMART set. So the SMART set will list all the alternatives that are recommended for this patient. And we also have our contact information in there. If they were to click here for further information, it would open up that one-page drug gene summary that I showed earlier on voriconazole so that they can read more. And in that one-page document, it also links directly to the CPIC guideline if they wanted to read even further. Now, the third challenge I wanted to talk about here is the adoption into routine practice and return of results. So in our clinical workflow currently, we leave it to the providers to identify patients who would benefit from testing. Sometimes we also get patients requesting testing, and we would also test those patients if they're willing to pay for the test. So our priority patients here are those that have had a history of adverse events or those with treatment failures. Also those that have immediate family history of these things, adverse events or treatment failures, those that have diagnosis that may warrant a pharmacogenetic medication, high-risk medication, especially, these are medication-specific, high-risk ancestry, sorry. These are medication specific. So for instance, with the clopidogrel example, then if you're of Asian ancestry, we highly recommend testing.
Two minutes
Yes.
remaining.
Yes, I'll be done soon. So for these patients here, they get a pre-test visit, they come back, the patient consents for testing, send their kit we send them a kit at home, they send it back to the lab, and once we receive, they go through a pharmacist-led visit where the pharmacist explains their results to them, discuss the recommendations, and the pharmacist writes a summary note to the ordering provider. Now, we've also developed an app to return the results to our patients. This is called PharmMe. So this is just some screenshots of the app, the gene report, they see this in here, and then they can open up, if they open up 2C19, they see which medications that they are currently on that they shouldn't be on, or the ones in the future that they should be aware of. So this is the page for voriconazole and the medication overview. And lastly, cost and reimbursement. This is the current landscape of reimbursement for pharmacogenomics in the US. All the green states here had something, according to CMS, they had the MolDX, which is local coverage determination in 2020, sorry. And then fast forward to 2021, Novitas and First Coast, so the darker gray states had coverage, but the lighter gray state didn't have coverage, which you see New York State did not have coverage as of 2021. And luckily, there's the biomarker testing legislation that's being pushed by the American Cancer Society. And with this testing, New York State recently got a legislation enacted that is requiring coverage for all insurance companies in the state to offer biomarker testing, including pharmacogenomics. So the test must be for diagnosis treatment, which helps us because then pharmacogenomics is here. And it's not limited to only cancer therapies, it's for all medications. And so this is just an overview of our program and what we've been doing so far. And I would like to acknowledge the folks that I work with. This is a team effort, and especially the PharmMe team, which is the app team based in the Haas-Plattner Institute in the University of Potsdam in Germany. And that would be it. Thank you very much.
Thank you. Our next speaker, Roseann Donnelly, who will talk about unique challenges with implementing G6PD genetic testing to prevent drug-induced hemolytic anemia.
Thank you. Good morning, everyone. It's a pleasure to be here this morning. We've already heard about several important implementation challenges with pharmacogenomics. In my talk, I'd like to focus on some unique challenges that are specific to G6PD. So first, by way of some brief background, G6PD, or glucose 6-phosphate dehydrogenase, is an enzyme that protects our red blood cells from oxidative damage. There are many different sources of oxidative stress, and these may include fava beans, infection, certain chemicals, as well as certain medications, including anti-infectives. And in somebody with normal G6PD enzyme activity, in the presence of these sources of oxidative stress, there are no adverse consequences. But in somebody with G6PD deficiency, because they have variants that predispose them to this, in the presence of these triggers, these red blood cells cannot handle the oxidative stress, and these patients can experience acute hemolytic anemia, which could be severe or life-threatening. G6PD deficiency is one of the oldest known and documented enzyme deficiencies, and it's one of the oldest known and documented pharmacogenetic associations with the anti-malarial primaquine. G6PD deficiency is one of the most common enzyme disorders worldwide, with about 500 million people estimated to be G6PD deficient. And if you take a look at the world map here, the darker regions correspond to increased prevalence of G6PD deficiency, and you'll note that we see a higher prevalence among patients of African, Southeast Asian, and Mediterranean ancestry. And interestingly, where we see higher prevalence of G6PD deficiency, this correlates where we see malaria to be endemic, as there is a heterozygote advantage here, with G6PD heterozygotes being protected from malaria mortality. Pathogenic variants in G6PD can result in two distinct clinical phenotypes. On the left here, we have the more common G6PD deficiency that's characterized by moderately to severely decreased G6PD activity. These patients are generally asymptomatic. They can go their whole lives and never know they have G6PD deficiency. It's only in the setting of a triggering agent that causes that increased oxidative stress where we can see that acute hemolytic anemia. On the other side, we have a more severe phenotype, which is G6PD deficiency with chronic non-spherocytic hemolytic anemia, or CNSHA. This is characterized by severely decreased G6PD enzyme activity levels, and these patients have chronic hemolysis at baseline. They are at risk for acute exacerbation of their chronic hemolytic anemia in response to those triggering agents that lead to increased oxidative stress. The genetic variants that cause G6PD deficiency with CNSHA are very rare. For decades now, the World Health Organization has provided a framework for the classification of G6PD variants, and in 2022, they underwent a revision of this classification system. You can see there are now 4 classes, A, B, C, and U, and these are defined by both the median of G6PD enzyme activity as well as the propensity to cause hemolysis. So the Class A variants are those that cause the CNSHA, that chronic hemolysis, and the Class B variants are the ones that cause the acute triggered hemolysis. I would like to acknowledge the efforts that are ongoing right now by the ClinGen G6PD variant curation expert panel. We are working towards classifying G6PD variants in accordance with the WHO classification system here. So this work is ongoing and certainly will help facilitate the implementation of G6PD genetic testing. So with that background in mind, this brings us to unique challenge number 1, which is that G6PD genetic testing may require follow-up enzyme activity testing to determine phenotype. And this is because the G6PD gene is located on the X chromosome. So if you're somebody with one X chromosome, the interpretation is fairly straightforward. If you have one normal function allele, you have normal G6PD enzyme activity. If you have one deficient allele, you have G6PD deficiency. Now, if you're somebody with 2 X chromosomes, it's also fairly straightforward if you're homozygous, either for the normal function allele or if you're homozygous for a deficient allele. And where it becomes a little tricky is with our heterozygous patients, somebody with 1 normal function allele and 1 deficient allele. Here we can say that the phenotype is variable, meaning these patients may have normal G6PD enzyme activity or they could have G6PD deficiency. And we don't know which is the case based on genetic testing alone. And this is because of X inactivation. So we don't know what proportion of red cells are actually expressing the normal function allele versus which proportion of red cells are expressing the deficient allele, and that proportion is going to determine what the expressed phenotype is. Does that patient have normal activity, or are they G6PD deficient? And the only way to figure that out is to do follow-up enzyme activity testing to measure that specifically. So in clinical practice today, by and large, G6PD testing is mostly done via enzyme activity testing, in part because of these challenges with interpreting the results in heterozygotes, but there are some limitations I'd like to point out here. First is that in heterozygotes, the result may change over the course of a patient's lifetime. Someone could have normal G6PD enzyme activity today, and then 10 years down the road be G6PD deficient. And so there is a need to potentially retest these patients in the future. In addition, G6PD enzyme activity assays are affected by hematologic parameters, such as those that are listed on the slide here. So for some groups of patients, such as those with cancer, anemia, or infections that may have these altered hematologic parameters, the G6PD activity test results for them may not be reliable. In response to this, my colleagues out of St. Jude Children's Research Hospital have been doing a lot of great work in this space with pharmacogenetics implementation in general, but with G6PD, what they've been doing is actually integrating both G6PD genotype and G6PD enzyme activity to come up with a more informed G6PD phenotype than either method alone. And if anyone is interested in learning about this further, I do refer you to the citation at the bottom of the slide. Unique challenge number 2 is that G6PD genetic testing may yield incidental findings. This is something that's not typical in the world of pharmacogenomics. We're not typically finding out about disease or disease risk from a pharmacogenomic test result. But because the G6PD gene is located on the X chromosome, there is a potential to detect chromosome abnormalities that may have been previously undiagnosed when somebody undergoes G6PD genetic testing. So this brings up the need for genetic counseling and potential diagnostic testing, such as through a karyotype. Unique challenge number 3 is that there have been conflicting recommendations about which drugs are actually unsafe in patients with G6PD deficiency. So if you take a look at regulatory agency warnings worldwide, if you take a look in the literature, you might see a recommendation from one source that says a medication is safe to use in patients with G6PD deficiency, and another source says it's absolutely unsafe and there's a high risk of that acute hemolytic anemia. This is compounded by the fact that the clinical evidence is sparse for many of these medications and may be limited to case reports. So because of this challenge, CPIC took this on a few years ago. The Clinical Pharmacogenetics Implementation Consortium assembled a team of international experts in order to evaluate the literature for medications that have been associated with potentially being unsafe in patients with G6PD deficiency. And this effort was led by Dr. Mary Relling. So what we did here is we did a systematic review of the literature for 48 medications that were identified by at least one source as potentially being unsafe in these patients and categorized them into high risk, medium risk, or low to no risk groups. So what did we find here? Well, first, the recommendations that I'm presenting here are for the more common phenotype of G6PD deficiency. The guideline does have some more stringent recommendations for that more severe phenotype with the chronic hemolysis. But in general here, you'll see that there are 7 high-risk medications, which the recommendation here is to avoid in patients with G6PD deficiency. I've highlighted the anti-infectives here in bold, and you'll see that dapsone, standard dose primaquine, and tafenoquine make the high-risk list. In the medium risk category, this is defined as those medications that should be used with caution in patients with G6PD deficiency, potentially with additional monitoring. Here we have nitrofurantoin and what I'm calling medium dose primaquine here. These are weekly doses that are recommended by CDC and WHO for the treatment of malaria in G6PD deficient patients. Now, what I think is perhaps more interesting to point out is that the vast majority of those 48 medications that were evaluated were classified into the low to no risk group, which is defined as you can use without regard to G6PD phenotype, and others were not given any recommendation because of the complete lack of data that was available. And so I think the bottom line here is that many anti-infectives, as well as other drugs that may have been thought to be unsafe in G6PD deficiency, actually don't have sufficient supporting evidence in the literature. And so clinician education is important to make sure clinicians are aware of where the evidence stands for these medications and what these updated CPIC recommendations are, so they can account for those in their clinical decision-making. And this brings us to our fourth and final unique challenge, which is leveraging G6PD genetic test results from newborn screening programs over time. This is a newer area. We're just starting to see G6PD testing integrated into some newborn screening programs in certain places in the country. Some of these programs may use enzyme activity testing, but others are using G6PD genetic testing. Now, the rationale for including G6PD in newborn screening programs is not a pharmacogenomic one per se. The rationale is that G6PD can cause neonatal hyperbilirubinemia, and early diagnosis can facilitate proper management and avoidance of bilirubin encephalopathy. Now, that being said, we all now know that there are pharmacogenomic implementation considerations here as well with G6PD, and so the challenges are, how are these results going to be documented into the electronic health record with clinical decision support, and importantly, how can these results follow the child throughout their life, especially if they are identified to be G6PD deficient. How can we ensure that they do not receive the high-risk medications, and also want to avoid redundant testing in the future if we got the information we needed from a newborn screening program. Now, because G6PD represents one of the first examples of a pharmacogene being integrated into newborn screening, lessons learned here could potentially be applied to other pharmacogenes that may make their way into newborn screening in the future. So in summary, we've covered today 4 unique challenges with G6PD, including G6PD genetic testing may require follow-up enzyme activity testing to determine phenotype. G6PD genetic testing may yield incidental findings. There have been conflicting recommendations about which drugs are unsafe in patients with G6PD deficiency, and leveraging G6PD genetic test results from newborn screening programs over time. Thank you for your attention, and I look forward to the discussion.
Thank you, Roseann. Our final speaker in this session is David Haas, who will talk about pharmacogenetics of antiviral agents. David?
Great. Thanks, Terry. Yeah, so it's my pleasure to speak this morning, and I realize there's a typo in the title, either an extra word or a word missing. So my background, I'm an infectious diseases physician primarily, who dabbles in pharmacogenetics, more than dabbles, but so I come to it from that perspective. And I was asked to talk about things that are ready for prime time, shovel ready, implementation science ready. I'll also make clear that I am not an implementation scientist. So I will talk about the various antiretroviral drugs and the potential for implementation science with these. Although almost all my past work has been in HIV and more recently in tuberculosis, I'll also talk about drugs used to treat hepatitis B, hepatitis C, herpes viruses, coronavirus, and pox viruses. Some overarching considerations to think about, and this doesn't just apply to what I'll be talking about, probably applies more broadly to pharmacogenetics, is how clinically important is the drug being considered? Are the therapies given of short course or chronic? When we think about pharmacogenetics, are we thinking about pharmacokinetic effects on drug disposition and exposure? Are we talking about being able to predict off-target toxicities? Right now in infectious diseases in many areas, there's the issue of giving pills daily or multiple times daily versus infrequent injectables. Do the pharmacogenetics affect drug-drug interactions, which is an area that I'm very interested in? Are the issues primarily domestic or global or both? And if we're talking about implementation, where on the implementation science spectrum are we talking? Are we talking about, at this moment getting it into the clinic and delivering, or are we a little bit further upstream? And what I didn't put on the list is, especially in the HIV space and some other spaces, some of the medications are delivered in co-formulated tablets with multiple drugs. So if you're going to do something to affect one drug, it may have implications for the other drugs as well. At present, there are 4 antiviral drugs for which there are CPIC guidelines, shown on this slide. Abacavir, interferon alpha treatments for hepatitis C, efavirenz, and atazanavir. And I'll say a few words about each of these. The HLA B5701 testing for abacavir is really the poster child, I think, for pharmacogenetics. And the good news is that this has been, at least in the US, as far as I can tell, very successfully implemented in clinical practice so that now people are not prescribed abacavir without knowing their HLA type. This was published in 2012. Of note, recently there's a big move away from abacavir for treating HIV infection. This is driven primarily by increasing data that abacavir is associated with cardiovascular events, including from recent analyses in the REPRIEVE trial recently presented. So in our clinic, which has several thousand HIV positive individuals, there's very frequent people being presented who are on a combination with abacavir where the presentation is to get them off the abacavir. So this is not really, it's already been implemented, and again, people moving away from abacavir. Yesterday we touched briefly on interferon-based therapies for hepatitis C. Here, genetics were shown to be very, very predictive of who would respond or not respond. Maybe that highly predictive is an overly enthusiastic word. But the reality is that the field has advanced so far that nobody, as far as I know, gets treated with interferon-based therapies for hepatitis C anymore. Rose is involved in some of these guidelines. First author on this, Rose just presented. The CPIC guideline for UGT1A1 for atazanavir, shown to predict hyperbilirubinemia and discontinuation of therapy. As with abacavir, atazanavir has been supplemented by much more preferred agents for treating HIV therapy. Within the protease inhibitor class, which atazanavir is, darunavir is a preferred drug because of its better resistance profile. So atazanavir is rarely prescribed in the US, as far as I know, anymore. And lastly, efavirenz, which done lots of work on over the years. CYP2B6 is very predictive of drug exposure and identifies people at higher risk of suicidality and other side effects. But again, because much more effective drugs have come along, relatively few people are being prescribed efavirenz, and people who have been on it are being taken off it to be on cleaner drugs these days. So of the 4 CPIC guidelines, they've had their time, but are not highly relevant to current prescribing for HIV. So here, this is not the complete list of drugs used to treat HIV. This is just a list of drugs used frequently these days in the US. The list is probably about twice this long. And I've ordered them from the top to bottom in terms of interest and importance. In terms of therapeutics, not in terms of necessarily lending themselves to pharmacogenetics. The top 2 newest drugs on the block are fostemsavir and lenacapavir. Fostemsavir is a drug that's effective in people with very highly drug-resistant HIV. It's an attachment inhibitor. the drug that's gotten the most press is lenacapavir, which can be administered once every 6 months and has been shown to be 100% effective in preventing infection, new infection with HIV, and is being used somewhat in therapeutics as well. For both those drugs, there doesn't appear to be a big pharmacogenetic role for lenacapavir. There's minor metabolism by CYP3A and UGT1A1, and fostemsavir with esterases and CYP3A4. This is not to say that there won't be off-target effects, but in terms of purely drug metabolism disposition, not a lot to go on. The biggest drug class used in the US, I'd say, are the integrase inhibitors, primarily dolutegravir and bictegravir for oral therapy, and cabotegravir, which is part of Cabenuva, for long-acting, like monthly or every other month injectable therapy. All of these drugs are substrates for UGT1A1, which does affect disposition of these drugs, as I'll talk a little bit more about. And these are really the go-to drugs, not just in the US, but globally for treating HIV. Millions and millions of people worldwide now are on dolutegravir-based therapy for HIV, and there's a shift toward perhaps more bictegravir in the future. Cabotegravir, its attractiveness is because of its long-acting injectable, and I'll show more about that in a second. Other drugs that are widely used, rilpivirine, doravirine, not big pharmacogenetic opportunities there, I don't think. Etravirine, I almost took off the list because it's not prescribed that much for HIV anymore, but it does have implications for pharmacogenetic effects, especially interactions with clopidogrel. I talked about abacavir already. And then there are nucleosides and nucleotides that are prescribed as part of combination therapy. They have minimal, as far as we know, pharmacogenetic implications. And then on the bottom, a protease inhibitor, darunavir boosted with cobicistat. This slide shows the impact of UGT1A1. It shows two things: the impact of UGT1A1 on dolutegravir. So I'm going to try to show the pointer. Oh, it works. So over here on the left is the effect of UGT1 genetic variants on trough levels of dolutegravir on people getting once daily dosing for treating HIV therapy. And you can see there's an impact here. But what's important to note that down here at the bottom, this dashed line is the IC95 for dolutegravir. So the levels are way in excess of what is needed to inhibit viral replication. What is shown over here on the right is in this clinical trial, I should have mentioned ACTG study A5372, people were then treated with treatment for latent M tuberculosis with a regimen that included rifapentine. Rifapentine is metabolized by ADAC, and a variant in ADAC affects rifapentine levels. And what we were able to show is that both your UGT1A1, which affects your dolutegravir directly, and your ADAC, which affects levels of rifapentine, combine to predict or are associated with a spectrum of dolutegravir exposure. And briefly, people who are slow rifapentine metabolizers have higher rifapentine levels, which then induces more hepatic enzyme, which then lowers your dolutegravir levels more. So if you're both a normal UGT1 metabolizer and a slow or poor ADAC metabolizer, those folks will have the lowest levels of dolutegravir. Cabotegravir, I mentioned being a UGT1A1 substrate and an important drug. On the left is what happens with UGT1A1 and cabotegravir, where clearly you have an association with poor metabolizers and higher levels. But cabotegravir, as being used to treat or prevent HIV, is given as an injectable. And this bypasses that liver effect, and the UGT1 variant really doesn't seem to have much of an effect in large clinical trial on plasma exposure with injectable cabotegravir. Now I'm going to quickly walk through the drugs to treat other infections, and it'll be quick because I'll tell you, not a lot to say. For the anti-Hep C drugs, the two drugs that are used primarily in clinical practice now in the U.S. are the ones that have kind of won out are the top two, Epclusa and Mavorette. I will not say that generic names are way too long. And both of these are widely used, very effective for treating hepatitis C with multi-week courses. There does not seem to be a lot of opportunity for pharmacogenetics here. They're either metabolized minimally or by multiple pathways. Really, the work now in hepatitis C therapeutics is trying to get these drugs to people who need them most, who are oftentimes hard-to-reach populations, and the move toward long-acting injectables so that a single dose given one time would be curative for hepatitis C for all viral subtypes. Hepatitis B drugs, these are largely treated with nucleoside analogs, especially at the top, entecavir, TAF, entecavir, and Truvada. And these really, although there are some pharmacogenetic effects, perhaps on renal toxicity with Truvada, they're minimal and not predictive enough to really be considered for use or translated into clinical practice. Similarly, for the anti-herpes virus drugs, and I'll point out with these are often, when given for therapy, given for very short courses, not so much if they're given for prophylaxis. But maybe the newest drug on the block, kit on the block, the letermovir, it is hepatically metabolized, but it's minimal with various enzymes. So not a lot of room for pharmacogenetics that I'm aware of for any of these drugs used to treat herpes viruses. For coronavirus, the JAK inhibitors listed at the top, especially what seems to be used most widely, baricitinib, is metabolized by CYP3A4. So in terms of direct effects, minimal pharmacogenetic opportunities. And again, here at the bottom, the drug Paxlovid, which is a protease inhibitor boosted by ritonavir, metabolized by CYP3A4. Not lots of
David, 2 minutes to wrap.
Okay, wrapping up. And lastly, tecovirimat, which has been used to treat Mpox. Minimal opportunity, and if you're not aware, there was a press release 2 days ago from the AIDS Clinical Trials Group where tecovirimat was used in a large study to try to treat people with Mpox, and the study was stopped enrollment early because tecovirimat was not shown to have any effect on either clearing of skin lesions or pain. So that is tecovirimat. And so to go back to my first slide, I've touched on potential contemporary antiviral drugs, including the list there, and I'm seeing a second typo on this slide as well. So I will stop there and be happy to, or I guess I'm the last in the group, so I'm leading us into the discussion.
Thank you. We now open it up for discussion. Terry?
Should we do our card thing like we did yesterday?
Yes.
Some people were not here.
Oh.
So I'll say, for
Right.
people who are not here, if you want to speak or ask a question, you're supposed to put your card up like that to be recognized.
Yeah, and if we don't see you, just wave or shout or something, but we'll try this. So I was wondering if we could ask Peter, when you identify someone at risk, or an infant or anyone at risk, do you use a different drug? Do you reduce the dose? You do both? I mean, what's the action to be taken?
Ideally, typically, that would be the way to go. Excuse me a moment. I was just disconnecting my Bluetooth connection to my computer, which was giving me the best audio that I can get to hear all around. So I was getting a great echo from from the room, and then this was disturbing my thoughts. So ideally, in answer to your question, that would be the best thing to do, but that isn't what happens clinically.
Which would be the best, a different drug or a lower dose?
So, yes, and so in the US it's easier to do because the cephalosporins are useful. They are narrow spectrum, and if the identity of the bug is known, then you can move on to the cephalosporins. And so in the US, that's a lot easier to do. When the bug is unknown, then that's when they tend to use the aminoglycoside. You don't have that luxury in other countries because the drugs are expensive. You don't know which bug it is, so you don't know what the testing is, and often the drugs are very labile and may degenerate at ambient temperatures, and so that's why the aminoglycosides are still continue to use. Another reason, if you don't know what kind of bug it is, if it's an intracellular drug, an intracellular bug like tularensis or other kinds of intracellular bacteria, then you really do need the aminoglycosides because they do enter the cells very easily, unlike the penicillins, which are really useful against extracellular bacteria, but not intracellular bacteria. So it all depends on the circumstances, and I'm sure I'm not covering all the clinical range of circumstances that might exist.
So we'll go to Gail, and then Dan, and then Bob, and then we'll come back up to the top of the table. So Gail, Dan, and then Bob.
Okay, so Roseann, I really enjoyed your talk about G6PD. I have a comment and question. My comment is I consider finding Klinefelters and Turners a bonus, not a challenge, but I understand people need to be aware that that can happen, but I think there's real benefit. My question was on the newborn screening, because last time I looked, only DC was doing newborn screening for G6PD. So what's the news on newborn screening?
Yes, so the paper that I cite on that slide is out of Mount Sinai in New York. They've implemented universal newborn screening with the enzyme activity testing at this time, and I guess there was a recent New York State mandate that you do G6PD testing for high-risk newborns, and the approach at Mount Sinai was just to do universal screening for everyone because of the challenges of identifying who might be high risk and who isn't from an equity standpoint. And in that paper, they do mention Washington, D.C. as having the genetic testing. They also mention the state of Pennsylvania having G6PD genetic testing as part of newborn screening as well. So those are the ones that I'm aware of at this time.
Dan?
So I'm going to ask an off-topic, or not off-topic, but seemingly off-topic G6PD question. There's a lot of interest in G6PD as a predictor of hemoglobin A1C and the implications of that for early diagnosis of diabetes and appropriate management of diabetes. And the 30-second version is that if you do a large GWAS on diabetic complications, particularly retinopathy, you find a screaming signal among African American men, because it's on the X chromosome, for G6, for a specific G6PD variant, the common variant, and the explanation for the susceptibility to diabetic retinopathy appears to be late diagnosis of diabetes, because using hemoglobin A1C is deceptive because your hemoglobin A1C is 5.5, but really it would be 7.5 if they didn't have chronic hemolysis, and then using hemoglobin A1C to track treatment also is ineffective because you're deceived into thinking that you're controlling it when you're not. So all of that is to ask the question, under what circumstances would an insurance payer pay for G6PD genetic testing? would evidence of low-grade hemolysis, for example, in an African-American man be reason enough? I think we're going to try to see, I think this community needs to start to think about using this kind of approach to identify people who are at high risk for diabetic complications. This seems like a no-brainer to me if the data hold up, but the obstacle may well be getting payers to pay. So Roseann, that's a long, long prologue to a question that might be try again later.
Yeah, the considerations with the association with diabetes and complications, that's a little bit outside of my wheelhouse. So I'm unable to really comment specifically on that. As far as insurance coverage, I can't say that I always understand why insurance companies cover what they do. I think sometimes that's a black box too. So I think it's unclear, you know, if they would find value in that, if the dollars work out in their favor. I think a lot of times that's driving the decision. And so that's, yeah, I really don't have any additional insight, I guess, other than that.
Maybe I could just speak directly
Under what
to the-
circumstances
no, I
would
guess
you order a G6PD genetic test in a middle-aged, if you had evidence of low-grade hemolysis in a middle-aged African-American male, would you order a G6PD test, and would you expect it? I mean, I guess I can't ask you if you expect it to be paid, because I, like you, have no sense of what it is they get excited about paying for or not. But would that be something that you would do in your clinical practice, or the clinical practice in which you live?
Yeah, I mean, I think that's reasonable because we know that the genetic variation can cause that. Now, if the patient is experiencing chronic hemolysis in the absence of a triggering agent, we would be suspecting one of those more severe variants, those class A variants versus class B, which is a lot more common, and that's the triggered hemolysis. And so that's something to think about as well. It is very rare to actually see G6PD deficiency with that chronic non-spherocytic hemolytic anemia.
Well, I mean, I don't want to, push this conversation. I know there are other speakers, but if you look hard for evidence of low-grade hemolysis, you may find, we think we may find a signal in the EHR in many G6PD carriers, not the signal that would rise to your clinical attention or to most people's clinical attention, but might be enough to trigger a test if we were interested in this diabetes question.
Carol, if I could just speak directly
Yes.
to that point. I'm just wondering if either of you could comment on what evidence would be needed to justify, or at least to try to convince a carrier to cover this, because it seems as though what Stephen told us yesterday was the only thing that was convincing was cost effectiveness. And I'm not sure how you demonstrate cost effectiveness with HbA1c and diabetes.
I mean, is that a question for me, or is it a
Sure.
question for
I mean, you
Roseann?
asked, so.
Yeah, no. I mean, isn't this a catch-22? Demonstrate cost effectiveness to us, but we're not going to help support any clinical trial that will demonstrate cost effectiveness. So it's sort of, you're ended up sort of chasing your tail. But so I think that's where we may be, in that space. It's a little bit off topic, so I just thought I would ask, but I think it's an important question. So
just a reminder, when you speak, you have to be uncomfortably close to this microphone for it to carry. And if you're not following along on the webinar itself, there are some interesting side discussions in the chat. So you might want to actually log into the meeting and if you have that link, and see the chat discussion as well. So we'll start down, Bob, and then David, and then we'll continue around for.
Pharmacogenetics is really a fantastic microcosm for the entire issue of implementing genomics in medicine. It has some of its own peculiarities, such as the fact that the turnaround time really needs to be very, very short. Well, one of the problems we came up with with introducing pharmacogenetics was physicians who said, I want to prescribe this drug now, and you're telling me I got to wait 2 weeks for me to figure out what to do. But that aside, it's absolutely clear to me that if you provide this test with great clinical validity and utility and say, build it, they will come, they won't. And that what you absolutely need to have is implementation from a centralized health organization that says, we're going to do this, and we're going to get clinical decision support of the appropriate kind into the EHR, we're going to get the ordering into the EHR, and that implementing genomics in medicine is not going to happen physician by physician. It's going to happen health system by health system. And I was very impressed with the Mount Sinai talk. I thought that was just absolutely fantastic.
Thank you.
David?
Yeah, so I have a question for Peter, and this may show my ignorance, which happens every time I open my mouth. But when we talk about genetics where mitochondrial variants affect risk, and if I remember correctly, mitochondria are inherited 100% from the mother. Can you do prediction based on doing testing of mothers and basically identify the risk for all the offspring from that mother?
That's very much outside of my area, but I would like to say that you're correct, but I don't have the experience to respond to that question, so to be determined.
I don't see why not, unless there's a high new mutation rate in the mitochondria to that allele. Those alleles are around in the population, so single-digit percentages, but they're there. And so I think you can very accurately predict that every offspring of a mother who's a carrier of one of these is going to be a carrier. I see no reason for that not to be the case.
I can't quite, is it Jonathan? Yeah.
Okay, so just sort of a general comment for all of the speakers, but maybe there seems to be a recurring theme in which drugs are being used, and we discover there's a pharmacogenetic interaction that we need to implement something for, but then better drugs come along and they are no longer subject to a pharmacogenomic interaction, and so now we're just using those drugs. I mean, and just sort of an open question, is this because older drugs are probably more likely derived from the types of compounds that we would have, as humans, evolved to have these sort of mechanisms against, and newer drugs being more, or maybe less reliant on those old sort of structures, don't go through the same pathways, or are the drug companies just getting better at selecting compounds that aren't going to have these types of effects? If that makes sense. Any thoughts on that?
Yeah, I think it's the latter. The drug companies, drugs that are dirty, that have lots of interactions, that have lots of metabolism issues, are not moved forward into development. And that's certainly been the case in the HIV space. And then I'll bring it back to Bob's comment. Just looking back historically, had all of this, had the genetic information been available a priori for drugs like efavirenz and atazanavir, and they would have been very, very widely used. So I really second the idea that that making the data available, it's much cheaper to do in pharmacogenetics than in much broader genomics, but that would have huge implications for this issue of having the genetic information be relevant while the drug is being most widely prescribed in that window of opportunity before the next better drug comes along.
If I could also add to this discussion, so a lot of preclinical testing is done with cells from other parts of the body rather than the inner ear, and so the inner ear is very small, it's a very specialized space, and you can't reproduce it in vitro. All the cells in the body take up aminoglycosides, and there are no real toxic effects. But when it gets into the inner ear, it gets concentrated within the sensory cells and also into the kidney cells. And that's when the toxic effects also begin to become apparent, because the sensory cells, for some reason, appear to be unable to clear the drug, unlike all the other cells in the rest of the body. And so it comes back to something that I raised in my summary slide, is that when these variants are there and they don't have any phenotypic effect, in my case, on the sense of hearing and balance, there is no way to predict whether such a variant is going to have an impact on the toxicity of aminoglycosides, whether it's accentuating the toxicity or is attenuating the toxicity, until we actually try it in a preclinical model, or even, in clinical trials to stage 4, once it's been released to the public and we start seeing an effect. And then if we could just go back to the other question about evolution over time. Well, aminoglycosides have been around for 80 years, and I don't think humans have had a time to evolve against any sort of protective mechanism against these drugs that have been identified in the last, century or two. But certainly the existence of variants like was described for the G6PD is very interesting. That has evolved as a mechanism against malaria, but we don't have a mechanism to protect ourselves against new drugs that are being developed now. And we're only just beginning to identify them, certainly in the case of ototoxicity, that were not known and did not even exist. We would not know about them until 20 years ago with the identification of mTRNR1.
So we'll go up this end, we'll come around, and then we'll hop to the other side of the room over there, and then start back down with Bob.
Thanks. Really exciting session, and I've learned a lot. I want to come back to Aniwaa and the discussions about Voriconazole. I think it's terrific to see the clinical decision support being used based on pharmacogenomics. And your efforts to educate clinicians are laudable, if difficult. I wonder how valuable this information is in persuading insurers that Voriconazole is the wrong drug. And I speak as a clinician here. It's very hard to get insurers to approve, say, Posaconazole, which is the logical choice in this setting. And the degree of toxicity people experience with Voriconazole, even I think in people that are normal metabolizers, is quite extraordinary. But the resistance to moving to more effective drugs from insurers is quite severe. And so I wonder if your information has been helpful in that regard.
That's a very good question. So we have actually not had that issue, but I anticipate it. And so for when it comes to actually justifying the testing costs, that's a different issue, right? Because now, especially with the inception of the new legislation, we don't have to worry so much about that. But to get the alternatives paid for, because they tend to be even more expensive than the Voriconazole, I anticipate that we actually have drafted certain letters that we can help the physicians with. I haven't had to use it yet. But I don't see that being a big issue. The reason why I say this is if we can justify the medical necessity. The patient has had this, we have the trough levels, we have the patient's response, and we have the genotype to actually back it up. I don't see why not. But I completely agree with you. This is the kind of information that we should be documenting to help pay for this, and insurance companies should actually pay for the alternatives in these cases.
Well, yeah. So just to pursue that a moment, are any of these data being used prospectively? That is, when you are getting ready to start a patient, say a cancer patient or something, on one of these drugs, can you use these data prospectively to go to an insurer to say, really, this is the wrong drug to use, don't push us to do something that's inappropriate?
So until this year, with the biomarker legislation, the MolDX recommendation actually required, prior to even the MolDX, they required you to have failed the therapy before they will pay for. It's not as proactive as we would like. That's the whole point of the testing, right? To avoid these side effects. So that's an evolving space. We would like to see what will happen, especially this year when more testing happening. And I mean, the end of the year is here already, but in 2025 and beyond, I would like to start collecting that kind of data to see. But most of the time, they would prefer that you would have failed the therapy first and then justify the new one, especially if it's not a tier 1 covered medication or something.
So I think just as an issue for Terry in particular, to make sure that we put into any report, the whole purpose of having information is to use it. And the failure-based approach to therapy that so many insurers have required is just maladaptive and really malpractice.
I second that.
Terry?
Yeah, I agree completely with Steve. It's like your comment about, you know, after your second, you know, intubation, you can come to us, et cetera. I did want to just comment briefly on David's point about sort of dirty drugs or drugs that can't be applied to everyone. And there's a good example with abacavir even before these other cardiovascular side effects were recognized, where once it was seen that there was this variant, basically, as I understand it, a lot of companies began pushing much more expensive drugs, so because you have this problem, and so we should just avoid it by giving everybody the more expensive ones instead of in resource-limited settings. You could do the test and get the abacavir. I put a note in the chat, just wondering if non-invasive prenatal testing picks up the mitochondrial DNA, and kind of wondering if anybody knows that, because the advantage there is that all of the mitochondrial DNA is going to be from the mother, right? Whether it's the infant or not, and so you'd be able to pick it up. If there's heteroplasmy, I guess that makes it a little more complicated, but just something to think about with NIPT is as to whether there are pharmacogenetics being looked at. I don't know.
Thank you. Yep, we'll go across here.
Yeah, sorry. I have a question for Dr. Donnelly and then a comment about...
Please speak right into that microphone.
I have a question for Dr. Donnelly and then a comment about Dr. Haas' presentation. The question for Dr. Donnelly is, why is G6PD not included in the ACMG list for secondary findings? I mean, I worked in the Gambia for many years, and that's really one variant. I mean, the set of variants they find in West Africa are so important in screening patients when they come to the clinic and prescribing drugs. And the comment about Dr. Haas is, we have data from Botswana showing that exposure to antiretroviral treatment during pregnancy has consequences down in life in terms of cognitive development and a lot of behavioral issues, right, in children treated with antiretrovirals, exposed to antiretrovirals during gestation. And we have data showing that there is a change in the epigenetic landscape in the genome of these children. So maybe that's an area that should be investigated as well. Thank you.
So to the first part of that, I'm not sure why they made that decision. I think it would make sense to return G6PD as a secondary finding. It is extremely common as far as genetic disorders go to have this, and it can be very impactful if you know this information and can prevent episodes of acute hemolytic anemia, which again could be severe or life-threatening. So if you have the sequencing data, I think that would be a good practice to do.
Can I respond to that? So I think they've generally steered away from pharmacogenetics for whatever decision was made. I'm not going to defend that decision, but I think that's why.
Yeah, if I can weigh in on this as well, having been part of at least some of these discussions. Gail is correct that there has been an avoidance of pharmacogenomics as part of secondary findings. Some of us advocated fairly strongly for that. It's still being considered. I tried to quickly look to see if G6PD has ever been nominated for consideration as a secondary finding, and I wasn't able to find that. But just to let the group know that there is an open nomination process for considerations for secondary findings. And so you can go to the ACMG site, get a nomination form, and it certainly would be good to put this forward so that the committee can consider whether this should be added in an update of the secondary findings list.
So Aniwaa and Dan, that's your to-do. No, just kidding.
Dan, do you want to go? Dan?
Yeah, so I just wanted to say that, I mean, the pharmacogenetic discussion it raises the question of sort of at what point do you just go ahead and do broad pharmacogenetic or genetic testing and stick that in the electronic medical record and leave it there fallow until a need arises, like a drug is prescribed. That's a philosophy that we've had in our program for preemptive pharmacogenetic testing for the last 15 years. We started with clopidogrel and CYP2C19. We're now up to about 25 or 30 drug gene pairs. And one of the frustrations that I have, and I probably shouldn't say this in public, is that I still don't have a sense of how often those data are accessed, how often those data are acted on, and more importantly, how often those data are accessed more than once. So the idea of doing preemptive genetic or pharmacogenetic testing is that you create a data set for a patient, and then over time, that patient gets exposed to multiple drugs. I mean, so Voriconazole and CYP2C19 has been on our panel for about the last 3 or 4 years. I wish I had a sense of how often it fires and how often people pay attention to it. But I think that's the way of the future. And I guess my job is to both advocate for G6PD to be included in the next version of the ACMG list and to figure out whether we have outcome data. David Haas can help me with that.
Thanks, Dan. So we'll go down to Bob and then Jillian.
Thanks. I just had a couple comments. One is CYP2C19 is covered by most insurance companies because of clopidogrel, because the alternatives are more expensive. So they'd rather you use that as a cheaper prodrug. Of course, if you're from the Pacific Oceania, you're out of luck with clopidogrel half of the time. The other comment I want to make is really a follow-up on Dan Roden's, which is our healthcare system is just not geared to using genomics in a preventive way. In the same way that, for example, doing carrier testing after someone's pregnant makes no sense. You've cut off many different channels of possibly helping people in a reproductively after the pregnancy is established. But getting carrier testing done before pregnancy, I found it to be very difficult because of the healthcare system. Well, getting PGX testing done in advance of needing a drug. I mean, how many people actually end up getting Voriconazole? So can you justify doing the PGX because of a possibility of using Voriconazole is so rare. But if you put them all together, which is the same idea with carrier testing, you now have something that is going to be actually applicable to most people at some point. So that if you can bring it back and have good clinical decision support so that it doesn't just get buried. I mean, you put it in a PDF into the electronic medical record and you can guarantee it'll never be looked at and never be used. I think would be very, very important to part of this. And finally, the last thing is we put G6PD on our proactive health screen at Invitae.
Yeah, just to quickly comment on that, I agree with you. When it comes to even Voriconazole, for 2C19 testing for Voriconazole, we've been able to implement this because people were testing 2C19 for Plavix, right? And we just wanted to make sure that everyone was getting the most benefit from that test. So most of the tests most of the BPAs that would even fire for Voriconazole were not originally ordered for Voriconazole. right? And so that has been our approach, because initially, like you said, 2C19 testing is covered, but not for voriconazole, or maybe now with the new LCDs that are out there. So we were just using every information that we get from the psych medication testing and from the clopidogrel testing, so 2C19, 2D6, and then we just added all the other medications that those results are applicable for. So that's why we even implemented voriconazole to begin with. And we have some internal studies that are ongoing with our biobank, and just to show the utility of a potential panel. So had a panel test been ordered the first time a patient in our biobank encountered a pharmacogenetic test, how often would they have used that panel within the first year and within the next 5 years? These are preliminary results that we haven't published yet, but anywhere from 65 to 99% of the time, based on what the initial medication was. So for instance, and I'm just looking at the slide here that I just recently presented, if the initial medication was an NSAID, they would have used another medication within the first year 65% of the time. But if the initial medication was clopidogrel, then within the first year, 89% of them would have used another PGX medication. So I hope that once we publish this data, the insurance companies will see the benefit for doing panel-based testing. And so that goes to your point and to Dan's point earlier as well.
And just to piggyback off of that as well, when you do panel testing for a dozen different pharmacogenes, 99% of the time you're going to have at least one actionable finding, if not many more. So there is potential to have a great value at the population level, and many of the medications that are used that do have pharmacogenomic implications are commonly used medications. So as Aniwaa presented, there's a high likelihood that someone over the course of their lifetime will potentially need a medication that interacts with their specific pharmacogenomic profile.
If I just comment on that, it's not just potentially. I think there's evidence from the Veterans Administration that panels do show
Yes.
actionable stuff, and that those people do get drugs that are covered in that panel.
Yes.
Jillian?
Okay, a couple of points to follow up on. To the question about G6PD and the payer landscape, I did look it up really quickly, and it looks like there are two major national payers who have non-coverage positions, and they're largely based on old and outdated guidelines included from the American Academy of Family Physicians, who said not to do G6PD genetic testing, and the current up-to-date guideline is pretty negative right now on G6PD testing. So all that to say, guidelines could probably change some of that coverage. There is one payer, Anthem Carelon, that does cover it for pharmacogenetic indications specifically. So that is one area where there's coverage. I also just wanted to iterate that the guidelines are a big part of the payer coverage landscape. So whether or not there are guidelines on how the guidelines are written, and specifically the opportunity to be moving, if we really want payers to pay it. So if it's a population level thing, then that's in the realm of public health and sort of outside of the commercial payer space. But if you want payers to pay for it, I think you have to move towards indication-based guidance for when this testing should be done rather than drug-based, because drug-based guidelines require by nature a manual review of whether a drug is being considered, because there are no ICD codes for considering this very specific drug. And so there's no way to automate the decision-making around that, and it will always require a medical director to review by prior auth or manual review whether a test is covered, which is automatically costly. And if you're talking about a test that costs a few $100s, you don't really want to spend a few $100s to decide whether or not to cover it. So I think that's a barrier. And so when I say indication-based coverage, I mean things like, should all transplant patients be getting a pharmacogenetic panel, and what are the outcomes for those patients? Should all cardiac patients be getting it? Should all people with immunodeficiencies be getting pharmacogenetic panels? I think those are the kinds of guidelines that would really move payer coverage in this space. And I wanted to end actually with a question to Aniwaa. I thought it was really interesting that you called out biomarker laws. We're in like such early days of those and trying to understand like how those laws will actually be implemented. And the pharmacogenetics is one of the more controversial parts of those laws, because it's, especially when you say it's not disease specific, because a lot of payers that I've talked to are getting really hung up on pharmacogenetics. Are they actually included in the biomarker laws? So I wondered, are you starting to see signs in New York that they are going to factor that into their implementation of the law?
I haven't had a rejection yet, so fingers crossed on that. But we are counting on them because based on the definition, that's why I had that slide on my in my presentation. Based on the definition, they're saying treatment as well, right, and appropriate management. So we hope that that's what pharmacogenetics, that's what justifies pharmacogenetic testing. But also the test must be cleared by the FDA or indicated for an FDA-approved drug, right? So once again, most of the users of pharmacogenetic medications have an FDA-approved indication. And or the test must have a local coverage determination from CMS, which the MolDX coverage justifies that. Or there has to be a nationally recognized practice guideline, not limited to NCCN or ASCO. So we hope that CPIC will justify that as well. So if you take all these criteria, we actually can check box all 4, but you just need 1. So hopefully we can justify PGX testing for the biomarker legislation. Yes, David.
Yes, David.
Yeah, so I have a thought to follow up with Gillian, what she just said about how we think about guidelines, and right now guidelines are largely, at least the CPIC guidelines are drug specific, and bringing this back to NHGRI and thinking about what could you do in this space, it would be great, maybe it's, you know, if there were, I think it would be great based on everything that's been said, if there were a guideline that said every patient being considered for transplantation or undergoing transplantation, and maybe it's certain organs should, you know, highly recommended that they have a pharmacogenetic panel done because we'll have so many implications. You kind of can take that from this meeting and distill it in your own mind, but it would be great to pull together, maybe it's been published already, you know, data to say that. And it would be wonderful if that's a major undertaking for NHGRI or somebody to put in money into that to say, you know, we will fund RFP or whatever, PA or whatever, to bring together available data to formulate new guidelines that will cut across fields, cardiovascular, whatever, to impact, you know, whether it's explicitly stated or not, impact the likelihood that an insurance company will actually pay for this test, because they go heavily to guidelines.
Thanks. Steve, and then we'll go across.
So to follow up on that in a slightly more generic way, I think most of us would say, my God, you know, transplant, that's just ridiculously simple. Anybody who's going into complex chemotherapy for any sort, that's really simple. But I wonder if what the numbers are. You know, if you said, if you're moving into an area in which you're likely to be on more than 3 medications or 5 medications, and I'll tell you for the people that I see in my clinic, that would be on the low end of disease activity. There must be numbers, I don't know what they are, that say, you know, the multiplier effect of having 3, 4, 5 medications puts you into a zone where justifying pharmacogenomics would be simple, or frankly, justifying genomics in general. But could we come up with sort of metrics that take us away from being disease-specific, important though that is, and get us into the more generic realm of saying we think drugs are an important problem, or we think drugs are an important impact on genomics? I would just, one other comment, speaking again as a simple clinician, trying to interpret the way that pharmacogenomics are reported, which is different than how regular genetics is reported. You know, it's good that there's so many stars on it because that's what I see when I try to read it. And I think it would be good if we were trying to come up with an integrated way that made it look like the rest of genomics so that regular humans like me could understand it.
So we'll go here, and then we'll go up, and then end down here. So go ahead.
Thank you. So I have 2 questions, and the first one might be easier to answer because I've been wondering how often are the newborn screening guidelines updated as new discoveries are being made, new markers are considered. How often, you know, do the guidelines and the tests actually change? That's the first one. The second one is more on the practical side of things. So somebody, let's say somebody gets genetic testing either as a newborn or later in life for particular indications, like transplantation, which I agree would make sense. But patients go through different healthcare systems, they see different providers, they change insurances over time. So I'm wondering, because genetic testing is so unique and the results stay with the patient alive for the entire life, how do we make sure that, first of all, the patient knows about the results, so he or she, is going to be the biggest advocate for getting or not getting a particular drug if they know they don't metabolize it properly or they have a reaction to it. And Aniwaa was mentioning the Pharmacogenetics app, which I thought would be a good way to go. Second, if that is not a possibility, how to ensure that there's I guess a permanent electronic health record or something similar that actually stays with the patient, while going through different systems in the US.
Thank you for that comment. I'm not sure about the frequency of, when they reevaluate the newborn screening guidelines. Maybe someone else in this room has better insight on that. But I think you hit on a really great point that because our healthcare system is so disjointed and we have a lack of interoperability between electronic health records, that presents a very real challenge for pharmacogenomic data, because we do want that to follow the patient. Patients don't just stay in one place. They don't just go to one hospital or one clinic or one pharmacy. They're moving around throughout their life, but these results are relevant throughout their lifetime. So that is a huge implementation challenge. I think you're absolutely right that we do need to be empowering patients and educating patients about their results and telling them that and making sure they are communicating that they have been tested with other providers if they do move and go see a new healthcare system, new providers, wherever they may be. And one potential solution out of Europe, when they did their preemptive pharmacogenomics program and published on that, they created what they called a safety code card, basically a wallet-sized card that had a list of the pharmacogenetic results and a QR code that they could bring to their local pharmacist or clinic, and that could be scanned. That would pull up online a portal where those providers could see the results and a corresponding medication recommendations. And that sort of system too can be updated, which is great because CPIC guidelines, for instance, are updated over time as new evidence emerges, and so we do need to make sure that the results are also linked to the most up-to-date medication recommendations when they're needed for a particular patient.
Yeah, and just to add to that, that was the main reason why we developed the Pharmacogenomics app. The main goal there is, one, to return the results to the patients in a friendly way, in a patient-friendly manner. So it's very simplified language, but also we use sentence blocks and sentence structures so that we can easily translate that app into Spanish. And because we are working with students based in Germany, we're going to do it in German and Italian as well. But mainly Spanish is our first rollout. One thing about patient empowerment, apart from the fact that they can take their results to other places, is that patient empowerment and knowledge about this will also encourage adoption. We don't realize how powerful that is. As more and more patients come into someone's clinic, asking for pharmacogenetics, I start to see those providers calling me to find out more about this. Mind you, 10 years ago, I knocked on their doors begging them to test, right? And they didn't want to do this. But now all of a sudden, because patients are asking, they want to learn more, they want to integrate. So then my focus has shifted from just, providers being my main stakeholders to patients. I'm trying to educate the patients to know about this field, and then they are the ones coming back asking to help drive more adoption. So yeah, that's why we did that with the Pharmy app.
So we'll go to Jennifer and then Terry and then Morgan, and then we'll be, I think, at time.
So I love this discussion. I think the PIDTC, this Primary Immune Deficiency Treatment Consortium, has been collecting a lot of sort of background data for its first 15 years, and it is now poised to make guidelines. I think they have a lot of experience and a deep database in many different diseases, and they work hand in hand with patient advocacy groups. So it sounds like a perfect combination to start coming out with treatment guidelines that should definitely include these pharmacogenomic aspects, which haven't been brought up before. So I can try to take that back to them, but I think this would be a very good concrete action item from this meeting to give us some expertise from the NHGRI to help with the PIDTC efforts on guidelines for Primary Immune Deficiency Treatment Consortium. Funded up until now by the RDCRN, the Rare Disease Consortia, but from now on within R24 from NIAID. So thanks to NIAID, and I think we really can, I mean, this is a very good one. We can do this.
So yeah, I wanted to make sort of two comments. One to Steve's comment about star alleles. Everybody hates star alleles, including the pharmacogeneticists. We're kind of stuck with them because, as you know, they're haplotypes, and so how do you? And I don't know that there's going to be a solution to that, but people have been looking at it. The other is that in the mention of bone marrow transplant patients, reminded me that we've been spending the past day talking about inborn errors of immunity, but then there's this whole bunch of people that have acquired errors or problems with immunity and immunocompromise, and obviously cancer patients and a whole variety of others. We haven't really addressed that at all, and I guess I would ask the infectious disease folks around the room, can you help us identify research directions that may be unique to acquired immunodeficiencies as opposed to congenital or inherited ones?
I would just add, it's not bone marrow alone, right? And there is a lot of transplantation that goes on. Every organ transplant is a lifelong commitment to complex medical therapy, not bone marrow transplant, but every organ transplant from the day it happens to the day they die, they're on a pile of drugs.
So who can help us with that? Nobody wants to step up, I think. Okay, well, we'll pursue it. Thanks, Carol.
Morgan.
Great, thank you. I've really enjoyed the conversation. Magda's going to talk about our program here in a minute at intramural NIAID under Steve's vision and leadership, but we've been very interested in a lot of the stuff that's going on, and I really applaud the work that you all are doing in the implementation of pharmacogenomics, and our experience certainly echoes Bob's comment about just because you build it doesn't mean that that it gets used. And so over the last year, we've been returning pharmacogenomic results as just part of our comprehensive genetic analysis that we do for all of our patients at NIAID. And I undertook an analysis of around 200 transplant patients from NIAID. So a number of these patients had GATA2, but a variety of other PIDs like CGD, so on and so forth, DOC8. And what we found was, of course, that, two really important things, right? So primary findings matter for transplant outcomes, as we know. Also, secondary findings matter for transplant outcomes. So also having TTR amyloidosis, for example, that this is statistically significant with your all-cause mortality stretched over several years following transplant, as is pharmacogenomics. So that's an abstract I presented and a manuscript I'm working on submitting now. But I think the data is there to be incorporated in some of the bigger efforts that Dr. Puck was talking about. At least it's suggestive.
Okay, well, we are a little bit over time, and I'm sure everyone needs a break, but I want to thank all of our speakers from this session for wonderful talks and wonderful discussion.
So because we recognize there are many of you who are anxious to get to your flights, can I ask that we try to stick to the 10:45 return, but really be back here by 10:45? Thanks.